clinically, the grade 3 is easily visible. Grade 2 varicocele, easily palpable but not visible. Grade 1 palpable only with Valsalva maneuver. However, in subclinical, it is not palpable, and only by Doppler ultrasound you can see the varicocele. These cases are not indicated for surgery. Diagnosis of varicocele depends also on the size of the prostate, of the testis, with Prader oxidometer, which is Wooding ellipsoid of increased volume, can visually compare the size of each testis. The ultrasound criteria of varicocelectomy is the diameter, which is normally below 2 millimeters, spermatic vein, and the retrograde flow is very important to be obvious in the ultrasound. There is abundant evidence that the varicocele may alter testicular growth, spermatogenesis, and fertility potential, and the cause of testicular injury is related to the scrotal temperature, but still the pathogenesis remains poorly understood. Treatment of varicocele is observation in of most of the cases. However, the main indication of surgical intervention remain significant. More than 20% left hypertrophy or decreased testicular size, or bilateral decreased testicular size, severe pain, or abnormal semen analysis above the age of 80 years. However, the pain is a rare indication for surgery, reported only up to 10% of patients in most cases. And even after the procedure, the relieving of the pain is not 100% sure. It's ranges from 60 to 90% of the case. So the semen analysis is very important in indications for varicocelectomy. And however, only 13% of cases of varicocelectomy worldwide has done semen analysis. It is varicocelectomy, of course, is the main operation used for treatment of infertility. The role is to repair the varicocelectomy, may halt the further damage to testicular function, and it can improve spermatogenesis, improve the live birth rate, better exit outcomes, and also enhances the Leydig cell function. Of course, the approaches are many, whether scrotal, inguinal, laparoscopic, or radiologic. However, the inguinal or subinguinal, when done microsurgically, this is the best technique and has the best evidence. The advantage of microsurgery is that you spare the testicular artery and the lymphatics using the available approaches, and the effect of the rate of the recurrence and hydrocele, which is very low rate in microsurgery. Advantages of the microsurgery: it allows the spermatic cord structure to be pulled out and out of the wound, so that the testicular artery, lymphatics, and small periarterial veins can be easily identified. Access to the external spermatic and even the gubernaculal veins, which can bypass the spermatic cord and result in recurrence if not ligated. Access to the testis for biopsy if you want. Substantial reduction in the incidence of the hydrocele formation, and avoid the complications of testicular atrophy or azoospermia. The technique: start by small incision only about 2 centimeters, and then by Babcock, you can deliver the penis, the cord from the wound, and after delivery of the cord, you open the layers under the microscope, the surgical microscope. As you can see, you have to preserve the artery and the vase. You can easily identify the lymphatics, so that you can you spare it and you decrease the incidence of hydrocele. And then you ligate the veins after sparing the important structures, which is the artery and the vase. At the end, all veins under the microscope can be ligated easily, and you spare the artery and lymphatics and the vase. Also, in recurrent cases, you have to deliver the penis from the wound, the testis from the wound, and ligate the gubernacular veins, and if any external spermatic perforators will have to be ligated. This is a review article on the effect of varicocele treatment on fertility in adults. It's a systematic review and meta-analysis with the relative risk of pregnancy in treatment group whose varicocele is better, however, not reaching statistically significant parameter. The sperm concentration, again, it is with the varicocelectomy group, however, not p-value is not significant. The sperm motility and normal morphology all at the varicocelectomy site. The sperm progressive motility, of course, is better in the varicocelectomy group. The mean difference of percentage of sperm with normal morphology during follow-up is better in the varicocelectomy group. And about the complication and recurrence, the least is in the microsurgical varicocelectomy group, up to 0.4% recurrence rate, while others are in the range of 5 to 10 to 30% recurrence. The AUA guidelines recommends that varicocele in adolescents with ipsilateral reduction in the testicular volume and the evidence of progressive testicular dysfunction, varicocelectomy should be done. Do not treat varicocele in infertile men who have normal semen analysis or in men with subclinical varicocele. Treat infertile men with clinical varicocele, abnormal semen parameters, and otherwise unexplained infertility. Varicocelectomy may be considered in men with raised DNA fragmentation with otherwise unexplained infertility who have suffered from failed assisted reproductive techniques. In future perspectives, refine the microsurgery and robotics are the future for treatment of varicocelectomy. Also, antioxidants and oxidative state modulation is still investigational, and regenerative approaches like stem cells are also experimental. In conclusion, surgery remains central for selected patient of male infertility. Outcomes hinge on the indication, technique, and couple factors. Integrated surgical plus assisted reproductive technique strategies offer the best chance of success. And I apologize for being so late. Thank you.